Professor Dr. Peter Slinger.
Hello, this is Peter Slinger. I'm an anesthesiologist in Toronto, Canada, and I'd like to speak to you about lung isolation with double lumen tubes and bronchial blockers. I'd like to thank Dr. Hazmi Mohammed very much for the invitation to speak to the Malaysian Society of Anesthesiologists. What we have on the first slide here is a diagram of the tracheobronchial tree with a left-sided double lumen tube, and we've passed a bronchoscope through the bronchial lumen of the left-sided tube, and when we look out the end, we can see the whole world. I'd like to talk to you about the ABCs, the fundamentals of lung isolation, and also some new equipment that's available to help us with lung isolation. We'll start with a case. These are the chest x-rays of a 75-year-old woman who's had a right pneumonectomy. The x-ray on the left is post-operative day 1. She had an uncomplicated pneumonectomy, and this is a normal post-pneumonectomy film. On day 7, she suddenly started coughing up large amounts of serous fluid. She became severely desaturated and dyspneic. She's had a dehiscence of her bronchial stump or a bronchial pleural fistula. And when this happens in the immediate period after a pneumonectomy, it's a life-threatening complication, and she's going to have to come back to the operating room and have this repaired. We'll need some form of lung isolation for this operation. Our choices are: we can use a single lumen tube and advance it as an endobronchial tube, we can use a double lumen tube, or we can use a bronchial blocker. The first method of lung isolation described was to use a single lumen tube. Now we can still take a standard endotracheal tube like pictured on the top here with the yellow circle and advance it as an endobronchial tube when we need to. Inside the yellow circle, it's about 4 centimeters from the distal orifice of the tube to the proximal cuff, and this will fit in the left mainstem bronchus, but on the right side it's bound to block the right upper lobe. The tube on the bottom with the blue circle, that's a commercially made endobronchial tube. It's very long, very flexible, has a very short cuff, no Murphy eye, so it can be used on the left side or the right side. However, these tubes are not widely available. Double lumen tubes are the lung isolation of most anesthesiologists. This is a diagram of the original double lumen tube, which was designed by Karlens. Karlens was a Swedish physiologist and respirologist, and he designed this tube to be placed awake in patients he was doing split lung function studies in. The tube has 2 cuffs, tracheal cuff and bronchial cuff, and 2 lumens, a bronchial lumen, tracheal lumen, and has this carinal hook as you see in the picture. Now, the problem with Karlens' tube was it had very small lumens. Karlens had actually taken 2 single lumen tubes, very small, and glued them together. So it was difficult to suction secretions through a Karlens. In the 1970s, an anesthesiologist in England redesigned Karlens' tube, and these are the tubes named after him, the Robert Shaw tube. If you cut one of these tubes in cross-section, it actually has 2 D-shaped lumens. These are very low flow resistance tubes, and they're better to suction secretions. Now, Karlens designed right-sided tubes for left-sided surgery and left-sided tubes for right-sided surgery. Disposable double lumen tubes are based on Robert Shaw's original design. These are 2 commercial disposable left-sided tubes. You can't always use a double lumen tube. This is a 20-year-old male. This is his chest x-ray. He was involved in a motor vehicle accident. He had a head injury and a left chest injury. He was intubated at the scene, and he arrived in the emergency with a cervical spine collar. They determined that he had left hemothorax. They put a left chest drain in and brought him emergently to the operating room for a left thoracotomy. And as you can imagine, it's not wise to try and change this single lumen tube to a double lumen tube in this case. So this is an excellent bronchial blocker. So difficult airways, good place to use a bronchial blocker. The first bronchial blocker designed to be placed through a standard single lumen tube was the Arndt bronchial blocker. The Arndt bronchial blocker has this, in the initial version, it had this odd pear-shaped cuff, and it has this very nice connector. It's got a lumen for the blocker, a lumen for the bronchoscope, and a lumen for your circuit, so you can ventilate and move the blocker and the bronchoscope. One thing about the ARNT is it had this loop, and this loop is designed to deliver the blocker to where you want it over the bronchoscope, sort of like a fireman sliding down. It can be a problem because you're actually advancing your bronchoscope ahead of the blocker, and sometimes the loop can get caught at the carina. This usually works. You can fiddle with it and eventually it goes, but it can. So there are other blockers now available. This is the Cohen blocker. The Cohen has a proximal wheel, and when you turn the wheel it deflects the distal tip, so you can turn it to the left. The Fuji company makes the uni blocker. They also make the univent tubes, but I do not like the univent tubes. But I like this blocker. This is the uni blocker. It basically has a very simple design, just a hockey stick, and you turn it to the left or turn it to the right. Several other blockers are very similar. The Cooptec and the VivaSight blockers. They're really the simplest of all the blockers, and I would say they're probably becoming the most popular blockers in North America right now. These blockers, you advance them ahead of your bronchoscope, as you see in the photograph here, and so if there is a problem with the airway, if it's abnormal, you can actually see where you're going, which is a big advantage. The newest blocker on the market is the Easy Blocker. This was designed by a Dutch anesthesiologist. It's actually two blockers. It's got two legs, a blue leg, a yellow leg. They each have a blocker. When you advance it, you don't know which leg is going to go, but you look with your bronchoscope and you inflate whichever one you need. I believe this blocker may be a little more stable than other blockers, but this is not a common belief. Many anesthesiologists who've used this blocker have reverted to other blockers like the Fuji blocker, because this blocker, you can imagine, it is a little bit fiddly to get it in place. You need to get this distal juncture right down on the carina. I don't think there's a clear winner as to which is the best blocker of the blockers available on the market. I think it's individual choice, individual experience, much like which kind of car do you drive or which kind of bicycle. It's personal preference. For me currently, it is the Easy Blocker, but I would say most of my colleagues prefer the Fuji blocker. One of the situations we find occasionally is the patient who has a tracheostomy or laryngectomy who requires lung isolation for thoracic surgery. Dr. Campos from Iowa collected 70 of these cases recently in thoracic vascular anesthesia. Basically, he recommends using a blocker when you have a tracheostomy. He says that if it's a fresh tracheostomy, less than 2 weeks, just use the in situ tracheostomy device. But if it's a mature tracheostomy, to replace the device with an endotracheal tube. An endotracheal tube gives you more flexibility in adjusting the depth of the cuff in the trachea. Sometimes the cuff is too close to the carina with the in situ device. Now, problem may be if the stoma is small. To use a blocker through and bronchoscope through an endotracheal tube, you require an endotracheal tube that's at least 7 millimeters. And so if it's a small tracheal stoma, as we see in this photograph here, you can pass the blocker externally to your endotracheal tube. You actually put the blocker in first, follow it with the tube, then put your bronchoscope through the tube, position the blocker, and then when you inflate the cuff of your endotracheal tube, it holds the blocker in place. This is something that also can be done orally, and it's frequently done in pediatrics, putting the blocker through the cords first, then following with a single lumen tube and a bronchoscope in the tube. Now, if it's a fresh tracheostomy and it's small, such as a 6 tracheostomy, 6 is the internal diameter, and you usually cannot get a blocker and fiber optic bronchoscope through both. But what you can, the outer cannula is a millimeter larger, and then you can get a standard endotracheal tube connector, put that in the outer cannula, and you have basically a 7 millimeter opening through which you can get a blocker and a bronch. One of the complaints that people have had about blockers is that they feel that the lung does not collapse as quickly with a blocker as with a double lumen tube. We actually did a study of this, which we published in Anesthesia and Analgesia. So on this diagram, we're using three different kinds of blockers and double lumen tubes. In yellow is the ART, green is the Cohen, and blue is the Fuji, red is double lumen tubes. And we're randomized patients to receive one of these devices, and then we had the surgeons grade the lung collapse when they opened the chest. 10 was complete collapse, 0 was no collapse. When they opened the chest, and the surgeons, by the way, were blinded, they didn't see what device we were using, and we actually hid it from them. So when they opened the chest, well, the lungs are all about 60% collapse. There's really no difference. At 10 minutes, they're all about 70% collapse, and at 20 minutes, they're all about 80% collapse. So there really is no difference in lung collapse if you're using a blocker or a double lumen tube, just to enable the surgeon to see in the chest to do the operation. There, because we did the exact same thing. We placed the bronchoscope into the bronchial lumen, and we advanced down to the carina. Now, sometimes when you do this, the tube will get stuck at the carina and you will have trouble advancing, or it will persist in going down the right side. And is that you get an assistant to push on the trachea to the right, and this will cause the carina to shift over to the right, and then you can advance your bronchoscope and your tube together under direct vision. So I want to stress that this is using the bronchoscope as a light, just like the headlights in your car when you drive at night. This is not using the bronchoscope like a Seldinger wire to advance the tube over it, because modern pediatric bronchoscopes are not designed for this. They're too flimsy, and often you fail when you try and do this. You just use the bronchoscope as the light, and you advance your bronchoscope under direct. Now, one situation that arises occasionally is a patient like this who's had previous left-sided surgery, and because of the loss of volume in her left lung, the bronchus, the left main stem bronchus, is now distorted. It makes a very large angle with the midline, and again you can have trouble getting a left-sided double lumen tube into this patient. Make tubes that have a reinforced distal lumen, and these tubes, the distal lumen of the bronchial lumen is very, very flexible, and they are very, very useful in this kind of patient because of the standard polyvinyl chloride tubes. They are very stiff tubes, and the tube can get stuck on the side wall of the bronchus if you have this kind of distortion. Fortunately, this can lead to this kind of injury, which is a laceration of the posteromedial wall of the left main stem bronchus. This is the carina here, left main stem bronchus, and that's a laceration caused by a left-sided double lumen tube. These tubes are very stiff. We have to be very, very gentle, and if there's any unusual resistance, again, we look with the bronchoscope and reevaluate where we are and advance under risk factors which have been described are patients who are elderly or short or female, patients having esophagectomy, previous radiotherapy, or multiple double lumen tube repositionings for this particular injury. So we have to be very careful with double lumen tubes. Here's a case of a patient with a difficult airway who requires lung isolation for anesthesia. This is the patient's chest x-ray on the right. This patient has a tumor of the proximal left main stem bronchus, and it has developed an abscess distal to the tumor. So this patient's coming for left lower lobectomy, but he also has pus in his chest. He's got an abscess. We'd like to really use a double lumen tube in cases with pus if possible. Now I've got his picture here because he's such a normal looking person. If you ask him to open his mouth, he has his own teeth, but he's basically a Mallampati 1. No obvious problem with his airway. However, the patient does have osteoarthritis of his cervical spine, and in a previous attempt at induction of anesthesia, he was a failed intubation, had to be woken up. So here we have a patient with a difficult airway that we'd really like to get a double lumen tube into. Now, How do we do this? Up until about 15 years ago, we'd have to do a fiber optic intubation with a double lumen tube, as we're demonstrating on this mannequin. However, our pediatric bronchoscopes, again, are not designed for this. They're barely long enough, and they tend to be too flimsy. However, you can do this. We certainly used to do it, but it is not an easy technique. You require excellent topical anesthesia, and it often requires about half an hour to achieve lung isolation with fiber optic bronchoscopy, positioning a double lumen tube. This is a manuscript from about 10 years ago when video laryngoscopes were first introduced in several hospitals, and in this particular 2 hospitals, the first year that they had video laryngoscopes available, they using the glide scope, they described a success rate after failed direct laryngoscopy of 94%. This is an amazing success rate, 94%. I don't know any technique that I can think of that has a 94. Even the goalie of our gold medal soccer team here in Canada, Stephanie Labbé, on penalty shots, she's only 50% save rate. So glide scope is obviously the major, and other video laryngoscopes, a major advance in intubation with single lumen tubes. But there are glide scopes and double lumen tubes. The glide scope was designed to mimic the curve of the tongue, as seen here on a CT. And often it's difficult to get a double lumen tube to follow the curve of a glide scope. So the glide scope is very good at showing us the glottis, as I'm sure you all know, but sometimes can be difficult in actually intubating. I've spent years trying to curve my double lumen tubes to follow the glide scope. But now, if I'm going to require using a glide scope because of what I prefer to do is to start with a single lumen tube and then to use a tube exchange catheter. Now, the only company that I know makes these is the Cook Company. They make 2 sizes, 11 and 14 French, and it's better to use the larger size whenever possible because it's slightly stiffer. And then we do a tube exchange. This study from a hospital in the United States found that there was a failure 40% of the time when they were trying to change from a single lumen tube to a double lumen tube using a tube exchanger. Now, these tube exchanges were done without the assistance of a video laryngoscope, which is one thing that makes this much easier. And another thing makes this easier is the type of endotracheal tube that you use. We have 3 different commercial left-sided double lumen tubes in this photograph. On the Ruche is the one on the left. And this was the tube that I was using. It's the standard tube in our hospitals. It has no bevel on the distal end. The Mallinckrodt tube in the middle has a small bevel, and the Fuji tube on the far right has a pronounced bevel and a very flexible distal bronchial lumen. So we'll now try and do this tube exchange using the Fuji tube. Since the original glide scope, there have been many imitations on the market. On the far right is the Stort CMAC, which is basically a Macintosh blade that is now a video scope. It's a line of sight type blade. In the middle is the McGrath, and there are several blades like the McGrath, which are, I think, somewhere between the 2, the hypercurved and the line of sight. So I find that if you're using the Stort CMAC, if you can get a good view of the glottis, then you do not have to do a tube exchange. You are usually able to intubate directly with the CMAC. I'm still learning which type of blade is best for which patient. For the patient that I showed you with a really limited motion of the cervical spine or a very small mouth opening, I think the hypercurve blades like the glide scope are best. But if you have a patient who just has a poor Malin-Patty view, such as an obese patient, however, has a good mouth opening and a good range of motion of the cervical spine, I find that the CMAC, the line of sight blades, are better. Now, the final case that I'll talk to you about is a 69-year-old woman who we had as a patient. She was scheduled for a thoracoscopic right upper lobectomy. She was seen in the anesthesia clinic pre-operatively, and it was noted that she had severe rheumatoid arthritis and she had neck pain. So the anesthesiologist who saw her very wisely asked for flexion extension views of her cervical spine. Here you can see in this x-ray that she has subluxation of C3 on C4, so she has some instability of her cervical spine. So we got a neurosurgical opinion. The neurosurgeon felt that in view of the patient's age and other comorbidities, that it was not indicated to surgically repair her cervical spine. So we were left with this patient who had an unstable cervical spine but still had lung cancer and needed surgery. So how to proceed with this case? Well, again, this is a difficult airway, and bronchial blockers work well in patients with difficult airways if all you need is lung collapse to facilitate surgery. So what we did with this patient is we did an awake fiber optic intubation with a single lumen tube. Then we passed a bronchial blocker and left it deflated. Then we positioned the patient on her side for surgery. And then once she was adequately positioned and comfortable, we induced anesthesia and then inflated the bronchial blocker. So again, blockers are very useful if you only need access for surgery and in patients with difficult airways. So, in summary, advances in lung isolation with double lumen tubes and bronchial blockers. Well, first of all, video bronchoscopes make it easier for us to see what the people that we're training, our residents and fellows, are doing when they're trying to position a blocker or a double lumen tube, and we're able to help each other. Video laryngoscopes are obviously a huge advance in lung isolation, not only for single lumen intubation, but also for double lumen tubes. We have some new bronchial blockers. I do not think the blockers in the last 5 years have made significant advances, and I think the choice of a bronchial blocker is largely up to the individual anesthesiologist, what their experience, and we do have some improved double lumen tubes that are useful in patients with difficult airways. We're left with the ABCs, the fundamentals of lung isolation. So we have to know the tracheal bronchial anatomy. We need to use the bronchoscope to look at the chest imaging use the bronchoscope and look at the chest imaging preoperatively. Again, thank you very much.
Thank you for your attention. See you next time in my other lectures.